My name is Rebecca Voss, and I'm a senior consultant with the Technical Assistance Collaborative. TAC was contracted by the University of Missouri, Kansas City to conduct an analysis of state strategies for funding recovery support services. This presentation is an overview of that analysis. I was joined in this effort by Jordan Gully, my colleague at TAC, as well as independent consultants John O'Brien, Victor Kaposha, Neil Campbell, and Colette Rose. I need to share the following disclaimer with you. Funding for this initiative was made possible by a grant from the Substance Abuse Mental Health Services Administration. The views expressed in this presentation do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of any trade names, commercial practices, or organizations imply endorsement by the U.S. government. This exploratory analysis was intended to answer the following questions. How much money are states spending on recovery support services and from what sources? And specifically, how much of funds allocated to states from the SAMHSA block and discretionary grants are dedicated to recovery supports? What are the types of recovery support services being purchased by states, such as peer recovery coaching or recovery housing or employment support? We wanted to know what types of organizations were receiving funds to provide these recovery supports. Were funds going to peer-run recovery community organizations or treatment providers or other entities? What kind of purchasing strategies do states use to fund recovery supports? Are or can these strategies be modified in any way? What do states identify as barriers to providing funding for recovery support services? And finally, are there means of non-financial assistance that states are employing to encourage the creation or expansion of recovery support services? To lay the foundation for this analysis, we needed to do some context setting and consulted with key informants to inform our processes and develop stakeholder buy-in and support. We conducted interviews with the Peer Recovery Center of Excellence Advisory Committee, leadership of the National Association of State Alcohol and Drug Abuse Directors, the National Council for Mental Well-Being, the National Institute on Alcohol Abuse and Alcoholism, the Recovery Research Institute at the Massachusetts General Hospital, the National Association of State Mental Health Program Directors, Faces and Voices of Recovery, the National Association of Recovery Residences, the Office of National Drug Control Policy, the National Institute on Drug Abuse, and SAMHSA. These interviews focused on identifying exemplary state practices to inform recommendations for in-depth interviews, identifying the research supporting effectiveness of recovery support services, an examination of federal and state policies relative to RSS expansion, and identification of any available research on financial and other means of support for recovery support services that's employed by states. We established a subject matter expert advisory committee based on recommendations from the key informants in our context setting interviews. The individuals listed on this slide represent a wealth of knowledge and expertise from leaders who have supported recovery support development and expansion at the federal, state, and local levels. Our committee included the voice of lived experience and provided a diverse array of experiences in government and RSS delivery to inform our approach. We are very grateful for their commitment to this process and assistance with the overall project. To begin the data gathering, we first worked to develop a definition of RSS to be used to promote consistency. Our data collection efforts included review of qualitative and quantitative information submitted to SAMHSA, key informant interviews with representatives from 10 single state agencies for substance use. Identification of these exemplary states was guided through the context setting process and through our subject matter expert advisory committee. And finally, a survey distributed to all states, territories, and municipalities that received block grant funding from SAMHSA. Our analysis included identification of other federal funding sources for recovery supports. It was really beyond the scope of this project to analyze each state's service definitions or other components of administration of recovery support services and recovery community organizations. So in order to understand the classification that were used for these services and organizations, it wasn't really possible to do that with each state. Knowing that, TAC developed working definitions of terms to help states categorize their recovery support service spending reporting. Even with this set of working definitions, there was considerable variability in some of the service classifications, especially recovery support. But it's important for you to identify the definitions used to guide your understanding in this presentation. So when we talk about recovery support services, it really was applying to all non-clinical supportive services aimed at supporting individuals with substance use disorder to reduce harm, access treatment, and sustain recovery. Recovery supports were defined as resources provided to help build recovery capital in the areas of social determinants of health and include basic needs assistance, transportation, childcare, employment assistance. And finally, recovery community organizations were defined as nonprofit organizations whose primary mission are to provide advocacy, education, and training and recovery support services and are led and governed by a majority of people in recovery. From the state survey, we received responses from 44 of the potential 56 respondents, providing an 84% response rate among the states with good representation across all regions. 42 states responded, 2 territories, and 1 municipality. Responses from Washington, D.C. are included in the Northeast region. Regional assignment of states is outlined in the text of the slide. There was interest in understanding whether or not Medicaid expansion status would impact response rates, and indeed we did see a greater percentage of expansion states that responded to the survey. In answering the question about the source of funding for recovery supports, our survey indicated an almost 1/3 split across substance abuse block grant, discretionary grants, and state funding. Of states that reported recovery support service funding, the total amount was $411.8 million in fiscal year 22. This chart reflects a lower total amount as one state was unable to break out the source of their spending due to blending of funds. This is an important piece to note that this is an important place to note that this analysis did not include state funding for recovery supports through Medicaid. And while this analysis establishes the first baseline of state spending from specific funding sources, many states are including supportive recovery supports through their Medicaid state plans. So to get a clearer picture of total spend, this would be an important consideration for any future analysis. In an attempt to create some baseline financial information and to compare spending across the 5 regions into which the states were organized, TAC looked at the range in per capita recovery support spending among all states and per capita recovery support spending across the geographic areas in 2 ways. For the per capita comparison, we first report per capita spending based on the entire state population, and second, by the prevalence per capita using state-specific substance use disorder prevalence estimates for individuals 12 and older, as found in the most recent National Survey on Drug Use and Health. It's again important to note that this spending report does not include Medicaid or spending from other non-SAMHSA federal funding sources. We further broke down the per capita spending by census and prevalence regionally. Our analysis demonstrated variations in regional recovery support spending, which differed when you looked at prevalence, especially notable when you look at the Southeast region, which was not among the highest spent by census, but had one of the highest rates when considering prevalence. We present this information only for foundational purposes, since there's no established benchmarks for the correct numbers in this area. This report presents descriptive statistics only, with no inferential analysis, given the exploratory nature of the data collection. With more sophisticated research, the differences presented here should be further analyzed to identify factors that drive the variation. TAC used each of the regional population per capita amounts to project spending for states that did not respond to the survey, and then to calculate projected national spending for all states. Using the regional average spend per capita, the rate was applied to the missing states' census data. This table indicates that the total national spend for recovery supports would be $775 million if all states had responded to the survey, which showed that 32 states spent $412 million in fiscal year 22. The survey instrument requested recovery support spending from the last completed federal fiscal year, which was fiscal year 22 at the time the survey was administered. In that fiscal year, there were significantly higher SAMHSA block grant allocations due to supplemental awards through COVID-19 funding and the American Rescue Plan Act. This impacted the calculation of the percentage of block grant allocated to recovery supports. Furthermore, there was a disparate impact on RSS spending across states due to the fact that ARPA provisions can be allocated until 2025. So the utilization rate of supplemental block grant funds varied across states. To mitigate this anomaly in the total block grant allocation, the team projected a percentage of block grant to be spent on recovery supports in federal fiscal year 23. This predication utilized the reported RSS spend from fiscal year 22 relative to the block grant state allocations for fiscal year 23, when block grant allotments would have returned to baseline. So if block grant spending stays the same, the majority of states will spend over 10% of the block grant on recovery supports, and some will spend over 25%. It is notable that 20% of respondents will be spending less than 20%. With the caveats noted about classification of the services, states are predominantly funding a mix of place-based services, recovery community centers, recovery housing, and peer support. The survey inquired about services that states funded, but the provided definition and terminology may have led to differences in interpretation, resulting in states reporting lower investments in workforce than in other classifications. As the survey did not explicitly ask about the state expenditures to support the peer workforce and workforce investments, such as training, recruitment, and retention efforts may have been underreported. Additionally, workforce investments are typically subject to administrative cap. Future surveys could focus more closely on investments for the peer workforce. Specific spending information was only provided for the 6 major categories of recovery support services, as discussed in the previous slide. In addition, states were asked to specify which services or activities they supported under the recovery support category, and this figure indicates states are supporting a wide array of specific services in the 24 categories that the survey listed. States fund a variety of organizational types to provide substance use disorder recovery supports, with recovery community organizations being the most prominent, and substance use disorder treatment providers the second most likely type. As with the caveat previously described about the percentage of funds spent on recovery supports, the fact that the third most likely category of funded organizations is other points to the need for further review with states to possibly create more useful organizational categories. Additionally, settings for recovery supports are provided or categorically consolidated. Recovery supports located in an SUD treatment setting were most prominent, followed by recovery community centers, justice, healthcare, and educational environments. And the survey states were asked to indicate what specialized RSS they fund in 13 population groups. States were most likely to target recovery supports to justice-involved populations, pregnant or postpartum individuals, and people who are homeless. They were least likely to tailor recovery supports to individuals whose preferred language is Spanish, those with disabilities, people who identify as LGBTQIA+, or older adults. Most regions included some states that targeted all 13 population groups. Through the review of block grant allocations and interviews with the targeted states, there were several strong initiatives that were identified for targeting specialized RSS and RCOs. In addition to the single state agency, other parts of state government support recovery support services and recovery community organizations. With growing attention to the prevalence of substance use disorders and opioid use disorder in particular, in the justice-involved population, it's not surprising that criminal justice was most frequently mentioned. Health and child welfare agencies are moderately active, and labor and housing agencies involved to a lesser degree. 34 states indicated that Medicaid provides coverage for recovery support services. However, in the 6 of these states, without Medicaid expansion, individuals with substance use disorders may not have full access to this benefit. An important consideration in a state's support of recovery support services is how it makes funds available to organizations and how they pay contractors once an award's made. States have procurement laws, systems, and requirements that vary widely and present different degrees of challenge and complexity for applicants to negotiate. States seek to strategically select purchasing strategies that are accountable, fair, transparent, and applicant-friendly, especially with a type of service that's relatively new and often provided by organizations with little or no experience applying for federal or state funding. This table represents strategies employed by states to increase funding for recovery support services and community-based organizations. Both the survey and in-depth interviews identified a wide range of non-financial state agency support functions provided to assure universal access to recovery support services and recovery community organizations, especially for underserved residents. This table identifies the number of responding states that provided one or more of these functions. 11 states provided all options of support, and 22 states provided at least 4. 31 states provided 3, and 35 states provided at least 2. Our analysis concluded with recommendations made to SAMHSA and states, and our first recommendation is that SAMHSA institute a requirement that states report the amount of substance abuse block grant and discretionary grant funds spent on recovery support services, and further that SAMHSA identify approximately 5 broad domains or categories of recovery supports that capture the type and function of services that make up the total of the expenditure. At a minimum, this state survey of financial expenditures, or one like it, should be continued, preferably on an annual but at least biennial basis, to build a reference point to draw conclusions about levels and methods of state spending for recovery support services. Both states and local recovery community organizations highlighted the need to expand the applicant field for competitive discretionary grants and provide infrastructure support for new organizations, focusing on new agencies serving underrepresented populations through creation of tiered funding models. Our recommendation is to establish a tiered funding model for discretionary grants, similar to tiers found in the National Institutes of Health funding. In order to facilitate the funding of previously underrepresented recipients, the tiers should evaluate with distinct criteria listed on this slide. We also felt that there was need to provide support for technical assistance, mutual learning, and training to states and from states to organizations. Multiple forms of support may include this: toolkits, learning collaboratives, targeted topic convenings, targeted topic training series. These forms of federal support or state support can advance best practices, optimize state expenditures, purchasing approaches, and payment policies, and ensure equitable access to recovery supports, especially for underserved geographic areas and populations previously unfunded providers of recovery support services. Such support could assist states in developing efficient methods for providing TA to newly funded organizations and in creating a sustainable funding plan for those providers. We also felt that there was a need to establish a representative consensus process that develops a taxonomy of recovery support services useful for reporting performance and outcomes. The taxonomy should identify major domains, essential components of each domain, key indicators of the components that can be tracked, reported, and accounted for, and illustrative examples of services or functions that represent those components. It's important to have consistency when reporting on these and definitions that are not state specific. We also felt that SAMHSA should establish a federal interagency recovery support service coordinating council that agrees to use standard definitions for recovery support services, uses standard reporting categories and units, and develops a strategy to provide funding available for recovery supports to promote optimum coverage and efficiency and avoid duplication. Members include SAMHSA, NIDA, HRSA, the Department of Justice, Housing and Urban Development, Department of Labor, CDC. We believe that an update of the systemic review of recovery support service effectiveness that was presented to the SAMHSA Recovery Research and Evaluation Technical Expert Panel in 2018 is appropriate. The summary report of this panel put forth recommendations to expand recovery research and to collect practice-based evidence from recovery support service providers and service users. An updated review incorporating both sources of information could bring stakeholders together in creating consensus to establish a forward-looking research agenda. And finally, SAMHSA's new Office of Recovery should establish and clarify SAMHSA's vision for recovery support services. This vision should specifically illuminate the current distinction between recovery support services for mental health and for substance use disorders. While some states are granting funding for mental health and substance use to support recovery support services and supporting an integrated approach, there appear to be conflicting views that support separation of the two systems. I'd like to use this opportunity to thank both SAMHSA and the University of Missouri, Kansas City for supporting this important work. I'd like also to express our thanks to individuals and organizations that participated in this process, with special appreciation extended to our subject matter expert advisory committee and state leaders who responded to the survey and took the time to speak with us individually. I invite you to follow the efforts of the Peer Recovery Center of Excellence on these social media links.